Part 2. Therapy. Chapter 10. An overview of avoidance reduction. I call my method of treating avoidance reduction to describe an approach to treating avoidant personality disorder, AvPD, that is dedicated, eclectic, holistic, and action-oriented. My therapeutic approach is dedicated because it is focused on the distancing process in all its aspects. It is eclectic and holistic because it uses multiple therapeutic techniques to deal with a broad range of core issues integral to AvPD, including, but not limited to, its developmental, psychodynamic, cognitive behavioral, interpersonal, and existential philosophical aspects, which, when taken together, make up the avoidant gestalt as summarized in Table 10.1. Table 10.1. Eclectic or holistic avoidance reduction. The analytic dimension. The therapist obtains information about and imparts insight into the dynamic aspects of the individual's avoidances. The information is obtained from a study of the patient's past life and of his or her current avoidant fantasies and behaviors, including transference, ideation, or behavior. The cognitive dimension. The therapist identifies and corrects illogical, inappropriate, and often paranoid interpersonal negative thinking, partly to help the patient recognize and acknowledge the positive aspects of relationships the patient currently views as all negative. The behavioral dimension. The therapist, informally or formally, asks the patient to perform a series of graded, non-avoidant, connective interpersonal tasks of progressive difficulty in order to approximate non-avoidance in a gradual, stepwise fashion. The interpersonal dimension. The therapist identifies and understands specific avoidant interpersonal anxieties and shows avoidants how the outer manifestations of anxiety or anxiety equivalents, such as shyness, can make others uncomfortable, leading others to react by thinking not "he is afraid of me," but "she is too stuck up to talk to me." The educative dimension. The therapist enhances motivation by enumerating the virtues of relating over being isolated and teaches the patient the social skills that can lead to pleasurable and rewarding experiences, which in turn inspire further attempts at fuller social mastery. The supportive dimension. The therapist provides the patient with a warm, reassuring, healing, holding therapeutic environment within which the therapist attempts to reduce relationship anxiety directly. For example, with such reassurances as, "You will get over your anxiety if you patiently persevere." The pharmacotherapeutic dimension. The doctor prescribes selected patients anti-anxiety and/or antidepressant agents, always keeping in mind that many patients would prefer to at least try verbal therapy before taking medication. My eclecticism is rooted in the work of Oldham and Maurice, who suggest an approach that involves desensitizing avoidance anxiety, helping avoidants learn social skills, helping avoidants consciously change some of their self-destructive thinking patterns, and using insight psychotherapy, which the authors believe can be highly beneficial for the avoidant person who has the courage to face instead of running away from his or her problems. It is also rooted in Millen and Davies' eclectic schema for treating avoidance, one that involves multitasking, that is, simultaneously using insight-oriented, interpersonal, cognitive behavioral, self-image, self-worth enhancing, and pharmacological therapy. Specifically, Millen and Davies suggest having avoidant patients 1. Understand their avoidance developmentally and dynamically. 2. Focus on increasing pleasure. 3. Learn to understand others. 4. Learn to differentiate between real, incidental, and imagined threats. 5. Develop internal and internalized realistic reference points by which to judge their own behavior. 6. Improve their self-image. 7. Make cognitive corrections or rework aversive schemas. 8. Use distraction methods such as positive social interaction. 9. Increase contact to acquire critical social skills. 10. Try new experiences which can help by enhancing and maintaining motivation and providing the opportunity to monitor behavior and correct maladaptive, automatic thoughts and irrational beliefs. 11. Learn to control fretful, expressive behavior while simultaneously establishing and improving friendships. And 12. Use indicated pharmacotherapeutic agents such as beta blockers, monoamine oxidase inhibitors, or serotonin uptake inhibitors to reduce anxiety. Millen and Davies further recommend that these different therapeutic modalities take place in a supportive setting where the therapist counters apprehension with free-handed empathy and support, the therapist's only recourse. My approach is action-oriented because it emphasizes doing as well as thinking. It goes beyond utilizing the more passive therapeutic techniques that rely exclusively on influencing and changing through understanding to emphasize the more active therapeutic techniques, particularly behavioral approaches, where the therapist exhorts patients to convert from avoidance to non-avoidance by facing their fears now as best they can through exposing themselves directly to situations that make them anxious, so that they can take that all-important leap from understanding what troubles them to actively doing something about it. Psychodynamically oriented psychotherapy. Psychodynamically oriented, psychoanalytically oriented, insight-oriented methods, a cornerstone of eclectic therapy, emphasize developing an understanding of the present manifestations of avoidance through identifying its enlarge, that is, its developmental origins. Thus, one avoidance present-day shyness was partly due to guilt about relating that originated in excessive closeness to a mother who discouraged her from getting involved with men by promoting the nonsensical belief that it was unthinkable for any daughter of hers to marry a stranger. A source of another's shyness was a fear of humiliation originating in her early relationship with a father who went out of his way to sport when she accomplished something significant, just so that he could avoid keeping her from getting a swell hate by paying her a compliment. Psychodynamically oriented therapists also explore to relieve the patient's present turmoil through developing an in-depth understanding of his or her current associations and fantasies in order to be able to fully answer such questions as, why exactly does asking a girl to dance make you so anxious? The answers often come from asking other questions such as, is it that you fear she will reject you? And if so, why should a stranger's rejection matter so much? Most psychodynamically oriented therapists try to help soften their patients' guilt feelings. They do that both by helping them become more accepting of impulses they currently renounce and by facilitating their use of healthier defenses to cope with guilt they cannot reduce or fully eliminate. Thus, patients might better come to deal with feeling guilty about hating others by relinquishing projection of their hatred. I don't hate you, you hate me, and instead denying and suppressing the hatred so that it shows less and therefore has less of a devastating effect on connectivity. Psychodynamically oriented therapists regularly identify and attempt to understand avoidances as they appear in the patient's negative actions with, based on transference to, the therapist, as when patients avoid an aspect of the therapeutic process, and even get therapists by cancelling appointments when something painful is about to surface. How does understanding insight cure? In simplistic terms, patients make things right by learning to unlearn what went wrong. Though much of the literature about AvPD downplays the importance of insight, citing, as do Anthony and Swinson, the likes of the lack of evidence for the effectiveness of understanding Freudian dynamics, I believe that insight-oriented approaches, while not sufficient, are necessary and synergize well with other approaches, particularly with cognitive behavioral therapy. Cognitive behavioral therapy. Eclectic therapists also use a cognitive behavioral approach focused on exposing and correcting the illogical thoughts that lead patients to distance themselves from relationships due to forming and maintaining excessively fearful notions about being criticized, humiliated, and rejected. Cognitive behavioral therapists correct thinking directly by reframing negative into neutral or more positive cognitions following the rules of evidence. They also correct thinking indirectly by suggesting behavioral interventions that consist of asking patients to do what makes them afraid in small, incremental steps as a way to slowly but surely reduce their anxious thinking, while simultaneously stirring up new anxious thoughts that the patients can bring back into therapy for further analysis and subsequent correction or integration. 2. They employ exhortation. I know you can do it, and try living around your need to distance even before the fears that lead to your distancing have been fully mastered, in order to goad patients into attempting successive approximations to healthy behaviors, hoping that they will gradually become habituated to the anxiety that predictably appears when they attempt to perform those very things that make them afraid. Many therapies use a combination of psychodynamically oriented and cognitive behavioral therapy. A case example: a patient who complained about being afraid to go out on a second date benefited both from learning about how her past affected her in the here and now, and from correcting her present misconceptions about dating directly so that she could feel calmer and act in a more productive fashion. For example, she once refused to have a second date with a man simply because he said that before making the next date with her, he had to check his schedule book. Correcting the cognitive error that I will get back to you equals I have rejected you was helpful, but not enough to change the emotional distortive thinking that came from deep within. To do this, we needed to go back to the beginning, when she first felt totally rejected over something similar and equally insignificant. Now, we discovered that her father was a man who, refusing to commit himself in advance to a specific time when they could get together, regularly told her when she asked him, "When can just the two of us have fun?" that "I will get back to you about that," then did not firm up a date for months, if at all. Understanding that you view all new boyfriends as your procrastinating father helped her see present relationships for what they were in the here and now, not as what she imagined them to be through the retrospectoscope of her past interactions with this parent. This insight acted synergistically with her new cognitive learning, the two together freeing her up to form a relationship that ultimately led to her getting happily married. Though advocates for cognitive therapy rarely speak of its downsides, there are shortcomings and complications of cognitive therapy that can interfere with improvement or make matters worse. Cognitive therapy is inherently critical, for, by definition, the therapist, however unintentionally, sends the patient two implied messages. Your thinking is wrong, and you personally are wrong-headed. Not messages avoidance, already notoriously sensitive to lack of support and feeling or being devalued, necessarily want to hear. Also, resistances appear to this as to every other form of therapy. Two of these are the positive resistance of falsely reporting progress to please or humor the therapist, obviously trying to be of help, and the negative resistance of stubbornly and even sadistically maintaining one's psychopathology to spite a therapist, too obviously pushing for change along lines the patient sees as predetermined and so deems to be controlling. The interpersonal approach. Eclectic therapists also use an interpersonal approach, where they study the dyadic causes and manifestations of avoidance with a view to resolving distorted interpersonal perceptions that lead to maladaptive interpersonal behavioral patterns, such as those that are the product of anxiety over intimacy. These therapies focus on the central interpersonal avoidant patterns and problems I emphasize throughout, such as fears of humiliation, criticism, and rejection at the hands of others, low self-esteem that makes it difficult for patients to confidently relate to other people, and the belief that serious closeness means completely losing rather than only partially compromising one's identity. Interpersonal therapists basically try to make it clear that avoidance expressed and secret interpersonal fears are excessive, and their perception of the dangers associated with relating are overblown. They usually attempt to interrupt cycles of negative feedback where avoidance actively creates some of the criticism they feel passively victimized by, after provoking others to mistreat them, less out of dislike and more out of fear. Supportive therapy. Eclectic therapists also use a supportive approach, involving positive feedback from the therapist. You are too good to fail. That's great that you have succeeded. Your low self-esteem is lower than by rights it should be. And reassurance. You can handle and overcome your anxiety. When indicated, they give fatherly or motherly advice. There are other places where you will be happier or more welcome or more popular than in the suburbs. Also, they often advise avoidance to seek succor from others who are potentially in a position to help. Secret sharers, counselors, friends, family members, and lovers who can, it is hoped, help the patient cope and feel better. And they use relaxation techniques such as teaching the patient to breathe deeply and more slowly, meditation, and when indicated, anti-anxiety pharmacotherapy. They do all these things and more within a comforting, therapeutic holding environment that serves as a kind of protective bubble for the patient attempting to venture forth into old and new anxiety-provoking interpersonal adventures. The existential approach. Eclectic therapists use an existential therapeutic approach consisting of reshaping the patient's philosophy of life. Methods involve helping the patient rethink favored avoidant positions and goals through identifying with and emulating others the patient admires for their social prowess and reading self-help books that take valid non-avoidant positions such as, when looking for a partner, be flexible about type and don't compare yourself to others. Family therapy. Eclectic therapists might use a family therapy approach, hoping to resolve interfamiliar conflicts that interfere with an individual's outside relationships. For example, they try to convince a smothering family to let go and stop infantilizing the patient by discouraging him or her from going out of the house, other at least than to go to work to support the family. Some case examples. Family therapy made it clear to a shy avoidant that she had become a remote, formal, rigid, and inhibited adult because she feared acting on her positive impulses without first getting parental approval, and because she feared losing control of her instincts in the heat of passion and saying and doing things that she would later be ashamed of because what her people thought or might think of her, that is, her reputation within the family, had become more important to her than what she thought of herself and then her personal growth, happiness, and satisfaction. We traced her excessive need for approval to her parents' continued warnings that people frown upon friendly women for being sluts and look down on a woman who is at all outgoing as being loose. A warning that her parents, as it became clear during our sessions, continued to issue for their own selfish purpose, to keep her at home just so that she would always be around and available to take care of them in case they needed her. She responded by entering a session wearing a t-shirt whose logo was 99% devil, 1% angel, her way to tell her parents and me that she had finally begun to break free from her inhibiting need to find out and buy into what her parents thought about and expected of her, and to obtain parental approval before she acted, instead of acknowledging her own feelings, then seeking personal direction. Next, having become less dependent on what her parents and anyone who reminded her of them thought, she was able to brave the inevitable criticisms and rejections that everyone gets in this world without becoming discouraged to the point that she couldn't do anything on her own without first having to ask for permission. Now she could try to connect with men without giving up easily, instead of fleeing out of a relationship at the first sign of closeness and, in retreat, figuratively going home again. Family therapy made it very clear to one avoidant that he was threatened by closeness because he worried about what his parents thought of his romantic relationships. In treatment, he learned to ask of his parents, "What's the worst that you can do to me?" Then to answer his own question by telling them, "If you continue in your old ways, I will simply have to stop talking to you." But still, his fear of parental disapproval persisted, making true intimacy with others impossible. So we next worked on helping him collect evidence on how the parental disapproval he so feared was less directed to him than it was the product of his parents' own distortive thinking, and therefore being relevant to them only was not an indication of how he should view and treat himself. In short, avoidance symptoms yield best to multiple approaches involving first, getting to the bottom of things, then patching things up by making a variety of repairs. Through diverse approaches might at first appear to be mutually inconsistent or even mutually exclusive, they can and should be used together, either alternatively or simultaneously. Because of the complex personality of the avoidant, a satisfyingly complete solution to the distancing problem can only be obtained through combined, multi-layered therapeutic interventions. Of course, not all avoidance should be treated exactly the same way. Different avoidants will need, desire, welcome, and respond to different treatment plans created to fit the individual's specific problematic interactive anxieties. The presence or absence of comorbidity, particularly the presence of paranoid and depressive tendencies, must be taken into account. Also important in formulating a treatment plan are the individual's personal preference for intellectual versus practical approaches. Current circumstances and needs. Patients with big supportive families often need less hand-holding than patients whose avoidance has left them all alone. And the degree of desire to change, as determined by personal aspirations and individual goals and ambitions, and ultimately influenced by therapist availability and cost. In the realm of the patient's personal problematic interactive anxieties, avoidants who are less fundamentally shy than fearful, such as commitment-phobic avoidants who would be outgoing, except for their long-standing, deeply ingrained interpersonal anxiety about becoming fully intimate, may benefit the most from exposure techniques combined with emotional support as they venture forth trying to overcome their all-the-world's stage fright. But patients who are temperamentally more shy and retiring than scared may benefit the most from an ongoing, long-term, supportive relationship with a therapist meant to tide them over, as the therapist acts the part of a healer who the patient can rely on long-term and cling to, as improvement, it is hoped, takes place, however slowly. The more intellectually oriented avoidants do best developing insight first, then acting on what they learned next, while the less intellectually oriented avoidants do best first doing, with understanding coming next, if at all. The first group of patients likes to contemplate a journey before, during, and after embarking on it. The second group of patients is satisfied just to be handed a roadmap. While the first group often does well being told, face your fears of parties so that we can analyze those fears as they arise, the second group often does well simply by being urged. Go to parties for progressively longer periods of time in graduated doses so that you will be able to slowly but surely to get used to mingling. Patients who tend to intellectualize do not take well to approaches that are exclusively total push, while patients who are more doers than thinkers feel stalled and cheated by therapists who seem only to want to talk first and expect action next, if at all. In the realm of differing individual goals, many avoidants are content to work around rather than attempt to fully overcome their anxiety. Just as social phobics afraid of being trapped in the theater can simply go through life happily sitting on the aisle in the back row, and social phobics afraid of heights who cannot sit in the theater balcony can, if they can avoid it, simply buy a comfortable seat in the orchestra or give up going to the theater altogether. Patients with AvPD can seek a lifetime of partial rather than full relationships, such as relationships with friends rather than lovers. paid strangers such as waiters or prostitutes, or relationships organized around impersonal gratifications they make subsidiary to interpersonal pleasures, such as the gratifications to be gotten from hobby clubs or group therapy. The therapeutic approach must also be geared to the individual style of relating. Some avoidants really like being isolated. Others are comfortable with a single codependent relationship, hopefully one that promises to last for a lifetime. Still, others look forward to only moderate connectivity so that they can have the best of both possible avoidant and non-avoidant worlds. And some look forward to leading a normal life with only modest compromise or, if possible, none at all. As to what approach to use first, avoidants who are very anxious or depressed about their lives, especially those who are experienced a series of losses, need support and sometimes pharmacotherapy in the beginning of therapy, with uncovering reserved for later, when the patient's realistic difficulties have become less or less urgent, so that what suffering there is has now become primarily of an existential nature, not a matter of what do I do to survive, but of how can I look at things differently so that I can feel more alive, connected, and joyful. My sessions fall naturally into the following pattern. We develop insight in one session, use the next session to develop a game plan for putting what we just learned into practice via inter-session exposure. Then have a session or two where we develop further insight, particularly into the anxiety aroused by these new exposure, with all sessions taking place in a setting of continuing support and reassurance along the lines of "you can do it" and "you will not faint or die when going out in public." Have another practice-oriented game plan session or two, and so on. A full working through process comes later. Here we cover the same ground repeatedly and in different contexts until it all sinks in, not only intellectually but also affectively, that is, emotionally, and practice makes perfect. Simultaneously, I attempt to handle the avoidance negative and positive resistances to therapy. Most avoidants start off wanting to be helpful to the therapist and to cooperate with treatment. At first, they work with the therapist in a joint endeavor meant to overcome their avoidance. They plead with the therapist to tell them what to do, to meet people, and how to overcome their relationship anxiety. Later, in treatment, however, they almost always begin to balk. Positive transference resistances develop where they use the therapist as too much the substitute for a real relationship. Negative transference resistances develop where they test the therapist often to the extreme. They disregard profit advice and sometimes even deliberately disrupt viable outside relationships in order to make the therapist look defective and impotent. They seek self-understanding only to misuse it. They say, "I will change when I learn," but either they never learn so that they don't have to change, or they learn intellectually but not emotionally so that they can continue to get the gratification that comes from complaining. "See, I've got insight, but it doesn't work." Laboring in therapy under a poor self-concept, feeling guilty about and fearful of criticism for their thoughts and feelings, and constantly worrying about whether or not the therapist approves of what they say or do, they become overly cautious and hesitant to discuss important matters openly. Afraid of all closeness, they begin to distance themselves from the therapist by being vocally negative about therapy and about the therapist. Coming to see the therapist as a parent, they refuse to get married just because you want me to, like my mother did, and otherwise fearfully turn an opportunity to grow into just another occasion to rebel. Finally, as Benjamin suggests, as easily injured individuals who readily feel degraded or put down by any therapist suggestions, they often boil over and abruptly quit therapy. In short, they use therapy as just another opportunity to become avoidant. Therefore, therapists must undercut their resistances both directly and indirectly. Undercutting resistances directly means working them out on a conscious level by pointing out who the therapist actually is and is not. For example, I am not a controlling parent or rival sibling, and by frequently and pointedly reminding patients that they should work with the therapist towards a common goal, not against the therapist towards developing just another avoidant relationship. Undercutting resistances indirectly means analyzing their unconscious origins with the goal of uncovering how present-day resistances are repetitions of old avoidant difficulties now reappearing with the therapist, and so not a thing to be accepted, tolerated, or condoned, but something to be subjected to the same corrective scrutiny as any other manifestation of avoidance occurring not only outside of, but also in the treatment room.